So it's sharp 5 o'clock, and students, we are deeply honored to have Dr. Kanagarajan. Sir is a very senior faculty of IACTA, has been teaching in the cardiac anesthesia circle for a long time. And he's a senior consultant in the Department of Cardiac Anesthesia in one of the iconic cardiac centers in our country, with many milestones that they set up together, the Madras Medical Mission in Chennai. Dr. Kanagarajan will be taking, we are starting our congenital journey in the FIACTA academic session now after finishing the adult part of the lectures. So sir will be first taking the transitional circulation, and then Tejashwini, who's one of our students, will be taking pulmonary hypertension, a very important topic. And there is no better person to moderate it, give his expert comments other than Dr. Kanagarajan. So thank you, and I welcome Dr. Kanagarajan to take over and start the session.
Thank you, Rahul, for your kind introduction. Yeah, at the outset, I like to thank the IACTA for the excellent academic initiative under you, and it's a really a wonderful program for the students, and really I'm looking forward to it. And because the adult program had done an excellent job for the students to teaching, and now the pediatric. And when it's up to start the topic with this, because most of the time we overlook the circulations as well as the embryology part of the congenital heart disease, because normally we don't look into that. But if we are able to understand that better, then we can understand the circulatory pathophysiology in a better sense, and we can manage the patients in much better conditions. Shall I start?
Yes, my only request to you is, can we go to the full screen mode?
Yeah, I'll do that. Yeah.
Thank you. Now this is perfect.
Yeah. Good afternoon or good evening, everybody. We will touch upon the fetal circulation first, then something about the fetal circulatory physiology. Then we move on to the transitional thing, and not much there for postnatal circulation except a few weeks following the birth. So, when you talk about the fetal circulation is a circulatory system of the human fetus. And this is the first system to develop in a fetus. The human fetal circulation begins when the heart first beats at approximately 22 days of gestation. So this system is a unique system in such a way that you have an intra and extra cardiac shunt that are present in the fetal circulatory system. And this is very important for the normal growth and development of the fetus, because the fetus is having an independent metabolism through the placenta. Now, coming to before going to the actual anatomy of the fetal circulations, let us look into some of the unique features of the fetal circulations. So, if you look at the fetal circulation, the first and foremost, the difference is placenta receives the deoxygenated blood from the fetal systemic organ. We know that how it differs from the normal circulations. And we know that the placenta is a richly vascularized organ, and this is the site for oxygenation as well as the nutrient delivery to the fetus. And it also carries away its wastages. Then it is such a unique system that the oxygenation actually takes external to the fetus. It's not happening inside the body of the fetus. It is happening outside the body. That is the placenta. And it is always mixing of venous return. And the most important thing is the preferential streaming. That is somewhat difficult to understand, but when you see that, you will understand. So the placental system, the fetal circulatory system, is optimized to deliver the highly oxygenated blood to the upper body. That is, the brain and heart receives a relatively highly saturated blood, when the lower body receives a relatively desaturated blood. This is because of the preferential streaming of the oxygenated blood and the presence of intracardiac and extracardiac shunt. And remember, this circulation is parallel, not in series. Another important thing is the right side pressures is higher than the pressures in the left or arterial system. Then comes the most important thing is the fetal myocardial energy. In contrary to the normal glucose which is required, it is primarily made by lactate extraction. Then another important adaptive response is your concentration of the hemoglobin. The fetal hemoglobin is 50% greater than the maternal blood. The advantage is at any given P50, that is a partial pressure of 50, the fetal hemoglobin can carry more oxygen than the maternal hemoglobin. The advantage is the fetal organs can extract oxygen even at low saturation. Then we know that the placenta is a low impedance, high blood flow system, in contrary to the pulmonary circulation, which is high impedance and low flow, because literally now flow in the pulmonary circulation in the fetus. Then another unique feature of this circulation is the 3 shunt, that is intracardiac shunts, that fetal shunts, ductus venosus, ductus arteriosus, and the foramen ovale. And they are very, very important for the distribution of the blood. They provide the blood pathways specific to the fetus, and they are important for maintaining the parallel circulation. So these are some of the unique features of the fetal circulation. So now go into a little detail about how the anatomy of the fetal circulation is there. They work differently because the lungs are not excluded from the circulations. The lungs are not used in the fetus. The fetus obtains oxygen nutrients from the mother through the placenta and the umbilical cord. This is you can easily see that this is a pictorial, this is a chart. Both are same only. Just for the better understanding, you can go through this by understanding this also. So you know that the venous return from the body, the systemic deoxygenated blood coming to the placenta through the umbilical artery. So you have 2 umbilical arteries. Then it's getting oxygenated in the placenta. Through the umbilical vein goes to the liver, and it is bypassed by 1 shunt here, that is ductus venosus. Around 30% goes to the IVC. It is bypassing the liver, around 30%. Then from the IVC, there is a preferential blood flow in the right atrium. The highly oxygenated blood streams through the foramen ovale and goes to the left atrium, then the left ventricle, then aorta and the lower body. Okay, aorta in the upper body. So the oxygenated blood streaming through the foramen ovale, supplying the head and the coronaries. Now, the rest of the IVC blood, which the SVC blood, as well as the remaining of the IVC, goes to the right ventricle, and we know that nothing goes through the pulmonary artery, so it goes through the ductus arteriosus. Here another shunt, and reaches the descending aorta, where supplies the lower body. So this blood is relatively desaturated compared to this blood. So you have a ductus venosus, you have a foramen ovale, and the ductus arteriosus. So there are 3 shunts which maintain the parallel circulation of the fetus. So now coming to the explanation. As I told you, the deoxygenated blood passes to the placenta via 2 umbilical arteries. They arise from the right and left internal iliac arteries. These are the umbilical arteries which are coming into the placenta. So here it is getting oxygenated and returned to the fetus via the umbilical vein. Okay. The unique thing is this blood flow in the umbilical vein gets splitted in the liver. Some of it goes to the hepatic vein and the portal system, and some of them goes through the fetal ductus venosus. This is the ductus venosus. This is your IVC. Okay. So the ductus venosus is like a trumpet, like a shunt, connecting the inferior vena cava near its junction to the right atrium. So 30% of the blood passes through the direct shunt, bypasses the liver. So the better oxygenated blood from the ductus venosus, if you just imagine that you have a pipe, okay, a tube like IVC, the posterior and leftward is having the blood is having a highly oxygenated and tend to stream separately than the what you call that anterior part of the blood. So it's if you understand this, it's much easier because you are having a same IVC, two column of blood. One is the posterior part, which is highly saturated, the anterior part, which is relatively desaturated. So on reaching the heart, again, that is how that IVC into streaming. The highly oxygenated stream shunted through the next shunt, that is the foramen ovale into the left atrium. This is the right atrium. This is going to the left atrium. So it crosses the left atrium, coming to the LV and getting ejected into the aorta, supplying the brain and the coronaries. So the highly saturated blood goes to the organs which needs the highest level of oxygen. The next stream, it goes from the RA, which is joined by the deoxygenated stream into the tricuspid band. This is a blue color. So you have a blood from the SVC and remaining the anterior part of the IVC, mixing in the RA, goes to the RV, then ejected into the pulmonary artery. See the saturation, 55% only. See the ascending aorta saturation, 65%. So it's a relatively desaturated blood. And we know that there is no flow into the lung. So through the ductus arteriosus, it's coming into the descending aorta to supply the lower part of the body. So this preferential streaming of the ductus venosus and the left hepatic venous blood through the foramen ovale distributes a highly oxygenated blood to the LA, and there will be always some mixing because of the pulmonary veins before entering into the left ventricle through the mitral valve. Then the ascending aorta delivers this oxygen-rich blood to the coronary arteries, the head and neck vessels, and upper extremities. So, nowhere only 10% of the cardiac output traverses the aortic arch and supplies the blood flow to the thoracic aorta. This is your preferential streaming. Okay, so you can see that through the foramen ovale, the oxygenated blood enter into the right atrium. Another preferentially goes to the right atrium. So this part of the blood is relatively desaturated, and the another one is saturated. Okay. Now, the most deoxygenated blood that is coming from the upper body through the SVC, from the coronary sinus, in addition to the IVC anteriorly streamed flow. This part of the blood, it coming into the right atrium, coming across the tricuspid valve into the RV, then ejected into the pulmonary artery. Now comes the third shunt, that is ductus arteriosus, which is from the pulmonary artery into the descending aorta, most distal to the left subclavian artery. So you can see here, that's what I explained you later before. So the tricuspid, the ductus arteriosus is as large as the aorta, because only the small amount of the right ventricle enters the pulmonary circulation. The more than the 90% goes through the descending aorta. So the lower half of the body is supplied with a relatively desaturated blood. Now, we have few things about how this fetal circulation getting controlled. Basically, it is controlled by the circulating catecholamines. Then locally released vasoactive substance all play a part. So we know that the catecholamines exert the activation of both alpha and beta adrenergic receptors, but they say that most of the time the fetal peripheral circulation is always little constricted. That is a tonic adrenergic influence. Predominantly, they are in the state of vasoconstriction by means of norepinephrine, arginine vasopressin, and the renin-angiotensin system. So you and me will respond to the hypoxia with a tachycardia, but the fetal heart responds to hypoxia with the bradycardia. And we know that the fetal pulmonary vascular resistance is high because the lung is filled with fluid free. Then there is always increased muscle mass and the resting vasomotor tone in the pulmonary vessels are very high. Now coming to the certain physiology, that is what is the blood volume, how it is distributed among the organs. Now fetal blood volume is as much as 110 to 115 ml per kg. So the blood volume in the fetus is between 10 to 12% of the body weight compared to 7 to 8% in the adult. Now at term or at the 28 weeks, the fetal blood pressure rose to almost 30 to 40 millimeter mercury, and the ventricle pressure, there is no change in the left ventricle or right ventricular pressures, even the diastolic ventricular pressures. Now, there are few changes or immaturity in the fetal cardiac function, which makes the fetal myocardium is unique in its function. One is they are structurally, functionally immature, and they have a more non-contractile elements, almost 60%. So they are little stiffer because there is an impaired relaxing property in the fetal myocardium. So the active atrial contraction is primarily responsible for emptying the atrium. So the active contraction is very important for maintaining the cardiac output. Second thing is it's a limited preload. So it can increase the stroke volume only by increasing the heart rate. So the heart rate may be the single most prominent means of increasing the cardiac output in the fetus. Look at the RV handles almost 55%, more than the LV. Second thing is the RV exhibits greater sensitive changes in the afterload more than the LV. So this can show in a nutshell that when you have a compliance, the fetus or the immediate neonatal period, the compliance is less, and the adult it is normal. And the most important thing is even in the immediate postnatal period, that is in the neonatal period, the cardiac output is heart rate dependent. This is very, very important because it takes few weeks for the neonatal myocardium to mature into an adult level. Now distribution, this is very, very important because the circulation is parallel. So even though the pressures are equal between two ventricles, the RV stroke volume is more. And here you use the word combined cardiac output because of the mixing happening. You don't talk about the LV output and the RV output separately. You say that it's a combined output. So the RV handles almost 1.2 to 1.3 times, and the LV is equal to 1%. Ratio is 1.2 to 1.3 is to 1. Now, if you look at the distribution, near terms, the left ventricle 40% and almost the right ventricle receives 60%, and your even the ductus arteriosus goes 39%. So it is increasing gradually. So the RV output, as we discussed, it is more into a pulmonary artery and the ductus arteriosus into the descending side, and the LV output is towards the coronary and the cerebral circulation. Now coming to the few important changes in the oxygen dissociation curve, or what we are calling as a fetal hemoglobin. The oxygen saturations are lower in the fetus than the neonates and infants. So relatively they are hypoxic environment. The fetus is always in the hypoxic environment. And the distribution of blood to the various organ and placenta is advantage that, like I said, the preferential streaming. The most important thing is the fetal hemoglobin at any given point, the P50 is more for the fetal hemoglobin than the adult. That means the organ can extract the oxygen even at the low saturation. So this is how the saturations are distributed. So you can see that most of the time it is like 65% even in ascending, and descending it is 60. So the relatively hypoxic environment for the fetus. Now coming to the transitional, so you are very clear in fetal circulations that it is a parallel circulation and it is having a 3 shunt, and there is a preferential streaming of more oxygenated blood into the upper body and the relatively desaturated blood into the lower body. So to maintain an effective circulatory pathway, you need all the three shunt in place. Now, transitional circulations. What do you mean by that? So now, immediately after birth, the transition has to happen from the parallel circulation to a circulation in series. That means the lung has to come into play, the RV has to eject into the pulmonary artery, then blood has to come to the LV, LA, then it has to go to the LV. So all the four chambers has to start receiving the blood. And most importantly, the shunts has to be closed. Okay. So the transitional circulation refers to the period when the fetal circulation transforms into the neonatal phenotype. Still, the neonate have some immaturity of the cardiovascular system, but the circulation is in series. It's a complex process, and it's like mathematics. It happens. First thing happens, followed by second thing happens. So it happens in a very ideal way. So soon after birth, this phase starts when the umbilical cord is clamped. So once you clamp the umbilical cord, then the lungs start aerating the first 2 deep breaths. This is the starting point for the entire transition. So the fetus must transit from a parallel circulation to a neonatal circulation in series. So what's happening? What are the major circulatory changes? The first thing is the placenta is eliminated. So you are removing a low impedance, high blood flow system from the neonatal circulation, the fetal circulation. Okay. Then the shunts has to be closed. So the closure of the fetal circulatory pathways. Then there is a gradual increase in the pulmonary blood flow into the lungs. So far the lungs are not in use, but now the lungs started receiving the blood. Then the LV start getting more blood because the ductus is closing off. So you start getting the LV output more. So this is what happening. Your ductus venosus out. There is a closure of your foramen ovale, and your ductus arteriosus is getting constricted. First, initially the functional closure, then the anatomical closure. Then your placenta had been clamped. So these are the major changes happening in the immediate. But how it happens? At birth, what is happening is immediate after birth, there is a dramatic fall in the PVR. Okay, there is 8 to 10-fold increase in pulmonary blood flow. They say that the major reason for this, the first breath, which inflate the lungs, are thought to stimulate the pulmonary stretch receptor, which mediate the reflex dilatation of the pulmonary vessel. So more than your cord clamping, it's the starting of the breath is the key reason in increase in the pulmonary blood flow and increase in the decrease in the PVR. Then mechanical distension of the lungs. Now the lungs start getting distended. It is displacing the fluid filled the lungs into the air filled lung. It promotes a local production of prostacyclin, a pulmonary artery vasodilator, which further decreasing the PVR. Now the improved oxygenation of the blood. So now the oxygen is improving. We know that oxygen is one of the potent pulmonary vasodilator. So this improved oxygenation acts as a vasodilator, both directly and through its ability to stimulate nitric oxide production. It all lead to reduction in the PVR, increase in the pulmonary blood flow, and most importantly, now the LA start getting blood directly from the pulmonary veins. So there is an increase in the venous return to the LA. So what's happening to the now all the shunt? So as soon as the placenta are removed, since you remove the placenta, there is a decrease in the blood flow across the ductus venosus. So the ductus passively closes, then almost within 10 days, it completely closes off. Then what is happening to the foramen ovale? We know that before birth, the right side pulses are more, left side pulses are less. So the RA pressure is more than the LA. So there is a shunt across the right to left. Now, because the LA starts releasing blood, the left side pressure started increasing. These allow equalization of the both the pressures. So the flap-like foramen oval is against the atrial septum and the shunt is functionally closed. So this initial functional closure of the foramen oval occurs within minutes to hours of the birth. Then anatomical closure occurs late. Now coming to the third shunt, the ductus arteriosus. The shunt at the level of ductus arteriosus become bidirectional. See, initially it is always from the right to left. The moment the oxygenation improves, the PVR drops, now the shunt reversed. So with the reduction of the PVR, the prostaglandin E2, which is the what you call a dilator of the PDA, the ductus arteriosus, and it's increase in the metabolism of the lungs. So one side, your production of E2 is decreased. Second thing, it is getting metabolized in the lung. So the ductus arteriosus start constricting. So in a healthy full term, the functional ductal closure, what we call as a functional closure by 4 days. That is first 2-3 days, it closes off. Then anatomical closure may take 2 to 3 weeks. So anything interfere with this physiological mechanism may cause persistence of ductus arteriosus, what you call as a PDA. So once the DA closes, the pulmonary artery reduces significantly as the PVR decreases. So it's almost 50% in within first 24 hours of life. And it will reach adult PVR. That is the, what you call neonatal PAH, neonatal pulmonary artery hypertension. That is a little higher PVR, reaches the adult level almost around 6 to 8 weeks. So it takes around 2 months for the. So if any pathophysiology persisting, this neonatal PAH may prolong more than 2 months, and the ductus arteriosus may remain open. So now put it in all together, look at the lungs first. So the lungs is initially replaced with the air. So you got pulmonary vasodilatation, decreased pulmonary vascular resistance, then increased pulmonary blood flow, increased pulmonary venous return to LA, then increased LA pressure, which closed the PF. Now this side, immediately after birth, then you have a decreased umbilicus venous blood flow to the right atrium. So the constriction of the umbilical artery, it's closes. So the placental circuit is lost, the systemic vascular resistance increases. So you have a PFO is closed. So these are the important changes. One is reduction in the PVR, then closure of all these shunts. This you can see very clearly that what is happening with the pulmonary arterial pressure, pulmonary blood flow, and the pulmonary vascular resistance weeks after birth. So within a week, your pulmonary vascular resistance drops significantly. Then your pulmonary blood flow goes up. Then your pulmonary arterial mean pressure is coming down. So this happens immediately after birth in a very significant way. Then this is what is happening before cord clamp. Then you clamp the cord, but the most important changes occur only after ventilation. So more than the cord clamping, it is the ventilation which makes a huge difference in the transitional circulation. So if you look at this black color, that is before cord clamp, the pulmonary blood flow, it's just around the zero. Okay, it's oscillation between the zero. Then even after the cord clamp, it doesn't increase much. But the moment its ventilation occurs, you get a huge increase in the pulmonary blood flow. The same thing, you can see the pulmonary blood flow, arterial pressure, then the carotid artery pressures, everything significantly improved after your ventilation. This is very interesting to know about the ductus arteriosus flow. Before the ventilation, before birth, it is a right to left. Then after that, it become a left to right shunt. So that is the significant changes in the ductus arteriosus flow. So now, what is happening to all the shunts and umbilical vein and umbilical artery anatomically? So we know that the ductus arteriosus become ligamentum arteriosus. Then the foramen ovale become ossa ovalis. Then the ductus venosus become ligamentum venosum. Then umbilical vein become incorporated in the ligamentum teres. Then your umbilical artery become a medial umbilical ligament. So these are the anatomical remnants of the intracardiac shunt in the fetal circulation. So this is after a few weeks or a few months where your normal circulation is happening. So this is a normal heart. That is what you call post, not in the immediate postnatal, I can say, but relatively maybe 1 or 2 months after. Even though your myocardium may be, the cardiovascular system may be immature and may take few weeks to few months to become an adult level. So you got a right atrium which receives the systemic venous blood. It goes to the right ventricle, then it goes to the pulmonary artery into the lungs. Then your left atrium receives blood from the pulmonary veins. Then coming to the LV, then it goes to aorta to the systemic circulation. So this is the normal circulation. So from the fetal circulation, which is totally depending on the external circulation, a transition period happening where all the shunts closing and loading the heart to become a normal circulations in a few weeks time. So now, as I told you, if any insult happens during the transitional period, then you can what they call as a persistence of the fetal circulation, especially if you have a hypoxia, hypercarbia, acidosis. That means the most important thing for the fetal circulation to become a transitional is reduction in the PVR. So if any condition causing not allowing the PVR to come down, that means your pulmonary blood flow is not increasing. If your pulmonary blood flow is not increasing, then the ductus arteriosus has to be there for a compatibility to survive. Okay, so that is what happening. So you have a pulmonary vasoconstriction, increased pulmonary vascular resistance, then the shunt remains the same. So it's very important in the neonatal period to avoid any insult which can decrease or increase the left to right and right to shunt. Okay. So as I told you, the immediate postnatal period, the ductus arteriosus start becoming a left to right shunt. And if it is persistent beyond certain weeks, what we call as a PDA, that is persistent ductus arteriosus, then it may lead to any left to right shunt can lead to increase in the PVR in the long term. Then if it is prolonged, it can lead to pulmonary vascular changes, which can lead to inverted shunt. That is the reversal of the shunt, or what you call Eisenmenger syndrome. So it's very important to know that most of the shunt persist because of the physiological changes which normally happening during the transition period didn't happen. So we know that as an anesthesiologist, you are well versed with this, that how can you increase the pulmonary output by decreasing the PVR, and how to do the increase in the systemic output. Because if you deal with any neonate with a left to right shunt or right to shunt or a duct dependent circulation, then balancing the SVR PVR is going to be the key in the managing the cardiac output. So to summarize, it is very important to understand certain physiological changes, certain embryologic changes of the congenital heart disease, the fetal circulation, neonatal circulation, to have a better understanding of pathophysiology of congenital heart disease and effective management of the circulation. Thank you very much. Manoj?
Yes, sir.
Yeah, I finished. Yeah.
Sir, now,
I
if
can
there are any
stop.
questions, you can answer, or else Dr. Tejashwini can start the presentation. Any discussion or questions? Can I answer?
Yeah.
So if you like to discuss something or have questions, you can proceed, or else
Yeah.
Dr. Tejaswini can start the presentation.
Yeah.
So can we ask Dr. Tejaswini to start the presentation? Kanagarajan sir, can you hear me?
Yeah, Manoj.
Yeah. Sir, can we ask Dr. Tejaswini to start the
Yeah,
presentation?
yeah, please, yeah.
Dr.
Yeah.
Tejaswini, please start your presentation.
Good evening, sir. Good evening, everyone. I'm Dr. Tejashwini. I have been allotted a topic pulmonary hypertension, definition, cause, and management under the guidance of Dr. Kanagarajan, sir. Pulmonary hypertension, introduction, is a pathophysiological disorder that may involve multiple clinical conditions and may be associated with variety of cardiovascular and respiratory diseases. The complexity of managing pulmonary hypertension requires a multifaceted, holistic, and multidisciplinary approach with active involvement of both patient and the clinicians. So according to the 2022 European Society of Cardiology and the Respiratory Society guidelines for the diagnosis and treatment of pulmonary hypertension, what is new about these guidelines? The 6th World Symposium has asked to reconsider the definition of pulmonary hypertension, cut off the level of pulmonary vascular resistance and definition of the exercise pH, revision of group 3 and group 5 classification. Screening strategies are also proposed. Initially, the screening strategy had included 3 strata model where the patients were categorized as low, intermediate, and high risk groups. Now it has been made into 4 strata risk assessment, which include low, intermediate, high, and high risk patients. So definition, pulmonary hypertension is defined as mean pulmonary artery pressure of more than 20 millimeters of mercury at rest. This is based on hemodynamic assessment by right heart catheterization, but the final diagnosis and the classification should reflect the whole clinical context and consider the results of all investigations of the patients. Hemodynamic definition of pulmonary hypertension. While defining the hemodynamic definition, we take into consideration the mean pulmonary artery pressure, pulmonary artery wedge pressure, and pulmonary vascular resistance. So pulmonary hypertension itself is defined as mean pulmonary artery pressure being more than 20 millimeters of mercury at rest. Pre-capillary pulmonary hypertension, mean pulmonary artery pressures are more than 20 millimeters of mercury. Wedge pressures are less than 15 millimeters of mercury, and pulmonary vascular resistance is more than 2 Wood units. If it is an isolated post-capillary pulmonary hypertension, pulmonary artery wedge pressures are more than 15 millimeters of mercury, and pulmonary vascular resistance is less than 2 Wood units. Both combined pre and post capillary pulmonary hypertension, mean pulmonary artery pressure stands out to be more than 20 millimeters of mercury. Wedge pressures are more than 50 millimeters of mercury, and pulmonary vascular resistance is more than 2 wood units. Exercise pulmonary hypertension, mean pulmonary artery pressures by the cardiac output slope between the rest and exercise is said to be more than 3 millimeters of mercury per liter per minute. Some patients often present with mean pulmonary artery pressures of more than 20 millimeters of mercury, but simultaneously the PVR is said to be less than 2 wood units and wedge pressures are less than 15 millimeters of mercury. Such patients are said to be unclassified pulmonary hypertension patients. So clinical classification of pulmonary hypertension, which is basically based on the cause. The purpose of this clinical classification stands out to categorize the patient and their clinical condition based on similar pathophysiological mechanism, clinical presentation of them, hemodynamic characteristics, and what is the treatment, what has to be given. So group 1 includes pulmonary artery hypertension. Group 2 is pulmonary hypertension associated with left heart disease. Group 3 is pulmonary hypertension associated with lung disease or hypoxia. Group 4 is pulmonary hypertension associated with pulmonary artery obstruction. Group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. Group 1, pulmonary artery hypertension. It's again subdivided into idiopathic, heritable, associated with drugs and toxin, associated with connective tissue disorder, fourth one, HIV, portal hypertension, congenital heart disease, schistosomiasis, pulmonary hypertension with features of venous and capillary involvement, and persistent pulmonary hypertension of newborn. Group 2, pulmonary hypertension associated with left heart disease. Basically, these are heart failure patients with preserved ejection fraction or with reduced or mildly reduced ejection fraction, or it could be second group of valvular heart disease patients, or it could be congenital acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. Group 3, pulmonary hypertension associated with the lung disease and or hypoxia, includes obstructive lung disease or emphysema, restrictive lung disease with both mixed restrictive and obstructive pattern, hypoventilation syndromes, hypoxia without lung disease, without lung disease like in high altitude, developmental lung disorders. Group 4, pulmonary hypertension associated with pulmonary artery obstructions, basically includes chronic thromboembolic pulmonary hypertension, and it could be other pulmonary artery obstructions too. Group 5, pulmonary hypertension with unclear or multifactorial mechanism, basically include hematological disorders, systemic disorders, metabolic disorders, chronic renal failure with or without hemodialysis, pulmonary tumor thrombotic microangiopathy, and fibrosing mediastinitis. We can see here in this figure, the prevalence of the pulmonary hypertension globally is said to be 1%. Among it, the presence of the cardiac and pulmonary causes of pulmonary hypertension stands out to be more. Hence, the prevalence is said to be higher in the older age groups who are more than 65 years. And globally, left heart disease is the leading cause of pulmonary hypertension, followed by COPD. Among the pulmonary artery hypertension, the most common is said to be the idiopathic variety, followed by connective tissue disorder, and followed by congenital heart disease, and then the portal hypertension-based pulmonary hypertension. So how do we go about diagnosing a pulmonary hypertension? Based on the clinical presentation of the patient, electrocardiogram, chest X-ray, pulmonary function test and ABG, echocardiography, VQ scan, CT and DSA, MRI, blood test immunology, cardiopulmonary exercise testing, right heart catheterization, vasoreactivity testing, and fluid challenge, genetic counseling and testing. So what is the diagnosis based on? The primary goal is to raise the early suspicion of pulmonary hypertension whenever the patient is approaching to a physician, and ensure a fast-track referral to a PH centers in patients with high likelihood of pulmonary hypertension or CTPH or pulmonary embolism. Second objective is to identify what is the underlying disease which is leading to pulmonary hypertension, such as left heart disease or lung disease or any other comorbidities. This helps basically proper classification of the disease and risk assessment and better approach for the treatment. Clinical presentation. The most common presentations are basically due to right ventricular dysfunction because of the pulmonary artery hypertension. These are manifested earlier during exercise. So the most common presentation, what they said to be is cardinal symptom of pulmonary hypertension is dyspnea. Dyspnea on exertion, fatigue and rapid exhaustion, dyspnea with bending forward, that is bendopnea, palpitation, hemoptysis, exercise-induced abnormal distension and nausea, weight gain due to fluid retention, and syncope. Rare symptoms such as Ottner syndrome because of compression of left recurrent laryngeal nerve, or it could be exertional chest pain because of compression of left main coronary artery, or shortness of breath, wheezing, cough, lower respiratory tract infection, and atelectasis. Other signs which can be seen because of pulmonary hypertension and the RV system involvement, basically because of the signs of PHR, central and peripheral mixed cyanosis, accentuated pulmonary component of the second heart sound, third heart sound of the RV, systolic murmur of TR, diastolic murmur of pulmonary regurgitation. The signs which are pointing towards the underlying cause of pulmonary hypertension, like digital clubbing because of cyanotic congenital heart disease or fibroptic lung disease or bronchiectasis, differential club cyanosis like in PD or Eisenmenger syndrome, auscultatory findings like lung and heart disease, sequelae of DVT, telangiectasis, sclerodactyly, etc. So what are signs of right ventricular backward failure? Distended and pulsating jugular veins, abdominal distension, hepatomegaly, ascites, peripheral edema. Signs of RV forward failure are peripheral cyanosis, dizziness, pallor, cool extremities, prolonged capillary refill. Next is ECG. ECG is done. This helps us to raise the suspicion of PH. It helps in giving the information about the prognosis of the patient, helps to detect arrhythmias, and also tells about the significance of the left heart disease. So typical ECG abnormalities seen are P pulmonale, a right axis deviation, RV hypertrophy, right bundle branch block, RV strain pattern, and prolonged QTC interval. Whenever the patient has a normal ECG, it doesn't mean it is excluding presence of pulmonary hypertension. Normal ECG along with normal biomarkers like BNP and NT-proBNP, then the chances of likelihood of having PH is lesser. Chest X-ray. Right heart, basically RA, RV, and PA enlargement are seen. There is pruning of peripheral vessels along with signs of underlying cause of PH like left heart disease or lung disease can be seen. Some of the signs which can be seen of the PH are right heart enlargement, PA enlargement, and water bottle shaped cardiac chylate. Curly B lines, pleural effusion, etc. also are quite common. And if it is a lung disease like flattening of diaphragm because of the emphysema is also seen, hyperlucency of the lung, and reticular opacification. PFT and ABG. This helps us to distinguish between the pH groups and assess the comorbidities and need of the O2 support for these patients and determine the disease severity. So the initial work of the pulmonary function test and the ABG basically includes force spirometry, body plethysmography, lung diffusion capacity for carbon monoxide, and ABG. Next comes the echocardiography. So because as we know, the basic pathology lying behind the pulmonary hypertension is the RV dysfunction. Hence the changes which are being seen in the echo are basically related to the RV. You can see the enlarged right ventricle, dilated RV with basal RV-LV ratio of being more than 1, flattened interventricular septum, hence leading D-shaped LV, distended inferior vena cava with diminished inspiratory collapsibility also can be present. If it is a forced inspiration, then the collapsibility is less than 20%. If it is minimal, then it is 50%. Then reduced right ventricular fractional area change of less than 30%. Decreased TAPSI. Then afterwards, enlarged right atrial area of more than 18 centimeters square area also is seen. So these are some of the additional echocardiographic signs which have already been told to you. Then comes a word on RV measurements. Basically, RV TAPSI, right ventricular fractional area change, RV free wall strain. Then tricuspid annulus velocity can be calculated. Right ventricular ejection fraction has to be calculated. Then NCCT, CECT, and DSA. The CT sign suggesting presence of pH. The three diagnostic signs most commonly considered when doing CT is whenever a PA diameter is more than 30 millimeter, RVUT wall thickness is more than or equal to 6 mm, septal deviation of more than 140 degree or RV by LV ratio of more than 1 is said to be diagnostic pH with other echocardiographic and the signs. Other findings also could be PA to iota ratio being more than 0.9. A right heart catheterization. Before that, word on DSA. DSA usually comes on diagnosis of CTPH. It helps us to treat what is the operability and accessibility of the underlying condition. Along with the CTPA, this also helps us to direct the indirect signs and the indirect signs of CTPH. So when we do a CTPA, we come to know about the filling defects, which could be because of thrombus, which is getting adherent to the vascular wall, or there could be webs, which are bands in PA, or it could be PA retraction or dilatation, mosaic pattern perfusion of the PA is seen, or enlarged bronchial arteries also can be visualized. Then comes the right heart catheterization. Right heart catheterization is said to be the gold standard for diagnosing and classifying pulmonary hypertension. Before we go ahead for cannulating the IJV and then do a right heart catheterization, what are the contraindications for right heart catheterization? Basically, whenever there is a thrombus in right ventricle or a RA, if the patient is having a triclip or a mechanical right heart valve, or if there is a pacemaker insertion recently done, that is less than 1 month, and if there is an acute infection, then right heart catheterization is being contraindicated in these patients. And the most weird complication what we have during right heart catheterization is perforation of the pulmonary artery. So the position for the patient during right heart catheterization is against supine mid-thoracic level is recommended as a 0 reference, because in most of the patients that is where LA is said to be lying. What are the variables that we get from right heart catheterization? Basically, the measured variables are right atrial pressure, pulmonary artery pressures, both systole and diastole, wedge pressures, mean pressures, cardiac output, mixed venous oxygen saturation, and the systolic blood pressures. What are the calculated parameters what we are obtaining from right heart catheterization are pulmonary vascular resistance, vascular resistance index, and cardiac index, stroke volume index. All the measurements including the pulmonary artery wedge pressure should be performed at the end of expiration without breath holding maneuver. Saturation which is taken with the catheter in wedge position can confirm an accurate pulmonary artery wedge pressures. A note on vasoreactivity testing. Vasoreactivity testing, the purpose of this test is to identify patients who are acute vasoresponders, in whom it is ideal to start high dose of calcium channel blockers. In 1958, Wood had administered acetylcholine in 6 patients who were diagnosed with idiopathic pulmonary artery hypertension, and he found that there is decrease in pulmonary artery pressure, decrease in pulmonary vascular resistance with increase in cardiac output. Hence, he came out to conclusion that there is a vasoconstriction pathology which is underlying this cause. Hence, whenever an ideal vasodilator is chosen, it should decrease the pulmonary vascular resistance with mean pulmonary artery pressure and increase in the cardiac output with mixed venous oxygen saturation to be increased. In this vasoreactive testing rhythm, we refer the patient to PH center. They do the right heart catheterization. Then during the testing, the acute or a positive acute response is been defined as reduction in mean pulmonary artery pressure by more than 10 millimeters of mercury to reach an absolute value of less than 40 millimeters of mercury with increased or unchanged cardiac output. But if patients are having pulmonary hypertension with left heart disease, vasoreactive testing is restricted to evaluate the heart transplantation candidacy. So the drugs which are commonly used for vasoreactive testing are inhaled nitric oxide, inhaled iloprost, IV epoprostenol, and injection adenosine. According to the newer guidelines of 2022 ESSC, it is told for inhaled nitric oxide and inhaled iloprost, the IV adenosine has been removed because of its complication and the side effects that has been observed. Nitric oxide basically is given by face mask with 100% of O2, starting with 10 ppm. Maximum of 40 ppm was the older guideline. Now they have maximized to 80 ppm. And similarly with the inhaled iloprost, we can begin the test with 2.5 microgram and then maximum up to 17 microgram. Next test is said to be fluid challenge test. Herein, we rapidly infuse about 500 ml of saline over 5 to 10 minutes. That would be sufficient to detect any abnormal increase in pulmonary artery wedge pressure of more than 18 millimeters of mercury. This suggests heart failure with preserved ejection fraction. All the validation and long-term evaluation of these data are to be needed. Fluid challenge will reveal us the LV diastole dysfunction patients with wedge pressures of less than 15 millimeter mercury, but a clinical phenotyping of this left heart disease patient has to be done. So the basically phenotyping of this patient suggests that whenever a patient is having pulmonary artery hypertension along with the left heart disease, then the age, the comorbidities, everything is taken into consideration when they are doing phenotyping. So the other test is genetic counseling and testing of these patients. Mutations in pulmonary artery hypertension genes have been identified in familial pulmonary artery hypertension, idiopathic and pulmonary vascular occlusive disease, pulmonary capillary hypertension, and eroxygen associated pulmonary artery hypertension. So WHO classification of functional status of pulmonary artery hypertension patients. This has a significance to tell us about the 1-year mortality and 1-year survival, and has been considered as one of the strongest predictor of survival both at diagnosis and even at follow-up. Anytime if there is a worsening of WHO functional classification, then it is one of the most alarming indicators that the disease has been progressing and initiative have to be taken for the aggressive treatment of the patient. So class 1 is patients with pulmonary hypertension, but without resulting limitation of physical activity. Ordinary physical activity does not cause any dyspnea to them, or fatigue, or chest pain, or near syncope. Class 2 are patients with pulmonary hypertension resulting in slight limitation of physical activity. They are comfortable at rest. Ordinary activity will causes undue dyspnea or fatigue, chest pain, or near syncope. Class 3 are patients with PH resulting in marked limitation of physical activity. They are comfortable at rest. Less than ordinary activity can be performed by them, will cause dyspnea, fatigue, chest pain, or near syncope. Class 4 are patients who are symptomatic at rest. These patients manifest signs of right heart failure, dyspnea, fatigue, maybe even at rest. Discomfort is increased by any physical activity. So diagnostic algorithm. A multi-step pragmatic approach is taken to diagnose a patient who is having pulmonary hypertension with unexplained dyspnea and other signs and symptoms. The first step is to make a suspicion. Whenever a patient is approaching us as a physician, initial evaluation has to be done, including medical history, physical examination, baseline ECG, along with BNP and NT-proBNP. Step 2 is to detect, which includes classifying the patient to which class they belong to, and includes other higher investigation like non-invasive lung and cardiac testing. Step 3 is confirming the patient that they are having pulmonary hypertension and referring them, if our center is not a pulmonary hypertension center, to a PH center. In situations like if they are intermediate or high probability of PH is established, or presence of risk factors of PH or pulmonary embolism are present. So this is a diagnostic table you can see. When patient has approached a general medical practitioner, medical history is obtained, physical examination is done, ECG, BNP, NT-proBNP, O2 saturation has been checked. If we have a fast track referral system and we diagnose the warning signs of PH and CTPH, if there are like pulmonary embolism, then directly refer the patient to PH center. But if you are suspecting if it could be a lung cause and PH or cardiac cause, then lung assessment like PFT, ABHC, chest X-ray has to be done. And then again, classify the patient and then assess. If it is a cardiac cause, again, heart assessment in terms of echocardiography and CEPT, and PH probability has to be assessed and then referred to PH center. So what are diagnostic features of different forms of pulmonary hypertension? Group 1 patients, what are the clinical features, and group 2 patients, what are the clinical features? This is just a differentiation table. When we say clinically, among the age group, it's group 1, it is the early age, whereas group 2, it is the elderly. O2 requirement is very much uncommon in both the groups. Chest X-ray shows changes in the right ventricle in the group A patients, whereas the left ventricular changes are more common in the group 2. Pulmonary function tests are quite normal in group 1 and also in 2. Echocardiographic changes of signs of PH are seen both in group 1 and group 2, but more of signs of right ventricle and the PH are seen in group 1 when compared to left heart disease and seen in group 2. Similar changes have been noted in group 3 and group 4 patients, where we are differentiating patients who are presenting to us. This is severity risk assessment tool. With this was this 3-strata model has been changed into 4-strata model. This is basically to assess the risk of the pulmonary arterial hypertension, who are at low risk, intermediate risk, and high risk. Basically, we are taking into consideration what are the signs of right heart failure, progression of the symptoms from the last 6 months, and is there any syncope, and what is the functional classification of work according to WHO and FC, 6-minute walking distance, and biomarkers like BNP, NT-BRO, PNP, echocardiographic parameters which include RA area and TAPC and pericardial effusion, and CRI, where we include basically right ventricular ejection fraction. So this has been turned into 4-strata model, which is including classically 4 things, that is functional classification, 6-minute walking distance, BNP, and NT-BRO and PNP. This basically has been done for the better classification of the patient and intervention according to the need of the patient. This is to assess for the follow-up of the patients when they have been diagnosed with PH. If it is green, it is said that that test has been indicated and it has to be done regularly. If the color is said to be yellow, then it is said to be, it can be considered. But if it is orange, it's said to be, it may be considered. So when we are treating the patients, what are the considerations have been taken? The general measures for the pulmonary arterial hypertension is how much is the physical activity and how much is the rehabilitation that the patient is receiving. Most of the patients, if they are being an intermediate high or high risk patient, they are often limited by the physical activity because they're always O2 dependent. So that has to be supervised, and then rehabilitation in terms of incentives and other things, and along with the medications. So the other would be anticoagulation. What is the necessity of anticoagulation in pulmonary arterial hypertension is another question. Whenever patients have been died and then the autopsy has been done, histopathological specimens have always showed thrombosis in the pulmonary vessels. So, and patients who are having congenital heart disease and PA aneurysms also have a tendency to develop thrombosis. And this states that there is a procoagulant state in these pulmonary arterial hypertension patients. Hence, it is necessary to start anticoagulation at low dose. But always keep in the mind that there is a risk of bleeding that has always had to be assessed. Then comes the role of diuretics. Right heart failure is the major component of the pulmonary arterial hypertension patients presenting with signs and symptoms. Right heart failure eventually leads to fluid retention. And this reduces the renal blood flow and hence activates the RAS system, because of which the GFR decreases and hence O2 delivery also decreases. So the main aim when we are treating with diuretics is to avoid the fluid retention is one of the key objectives in these pulmonary arterial hypertension patients. Oxygen is said to decrease the pulmonary vascular resistance and improve the exercise tolerance of the patients in PH. If the patient is having pulmonary arterial hypertension that is secondary to a lung disease, be it a COPD, then the baseline ABG will tell us what is the partial pressure of O2 in this patient. So if it is less than 60 millimeters of mercury, if it is measured at more than 2 occasions, then we are advised to start O2 treatment of these patients. Ambulatory O2 also is considered if the patient is said to be desaturating whenever they are doing exercise. Nocturnal O2 is advised in patients who are having sleep-related desaturation. Anemia and cardiovascular drugs, basically in terms of left heart failure treatment and hypertension treatment. including ARBs, ARNIs, and beta blockers, and ivabradine. Anemia and iron status. Iron deficiency is very common in pulmonary arterial hypertension. So serum ferritin levels, if it is said to be less than 100 microgram per liter, and transferrin saturation if it is said to be less than 20%. And if the hemoglobin is less than 7 to 8 grams, then it is better to go ahead with the IV supplementation of the iron to these patients. The other consideration is that vaccination. These patients have to be vaccinated against influenza, Streptococcus pneumonia, and SARS-CoV-2. Then psychosocial support. Patients are said to be moribund, and they need persistent adherence of support both psychologically and physically because of the medications and the treatment they are taking. Most of them are known to have depression on a long side treatment. Hence, they have to be supported both socially and psychologically. And adherence to treatment is a big task. So both family members, the patient himself, and the team of the PH center should be working on adherence of the treatment of these patients. So what are the therapies in per se for treating the patients with pulmonary artery hypertension as per se? Basically, we are coming up with the calcium channel blockers, including amlodipine, diltiazem, nifedipine. As we have already seen, when they very much respond to acute vasoreactive testing. Hence, calcium channel blockers are one of the initial treatment that is being used, including idiopathic pulmonary artery hypertension patients. The other group include endothelin receptor antagonist. Basically, endothelin 1 is a one which binds to receptors both A and B, which is present on pulmonary artery smooth muscles, and this is known to cause vasoconstriction and proliferation. Hence, the antagonists are being used. Oral medications are bosentan, mesentan, ambrisentan. Then the other is phosphodiesterase 5 inhibitors, including sildenafil and tadalafil. Prostacyclin analogs include both oral and IV or inhaled. Oral are bepraprost and treprostinil, and inhaled are iloprost and treprostinil. Prostacyclin receptor agonists include a selexipag, and soluble guanide cyclase stimulator include riociguat. This is what has been told. This is again there in the guideline. This is what been told according to the starting dose and the target dose to be achieved for every patient whenever we are starting the medication. Interventional therapy. Interventional therapy basically includes balloon arterial septostomy. Here we are creating an interatrial shunt. In a port shunt, we are creating connection between left pulmonary artery and the descending aorta. The entire aim of this both is to decompress the right heart, increase systemic blood flow, and then improve the system O2 transport, in spite of knowing that the arterial O2 desaturation is yet to happen. Pulmonary artery denervation. This is considered because pulmonary artery hypertension is said to be associated with increased sympathetic overdrive. Hence, this is one of the other mode to go as an intervention therapy. The last would be lung and heart-lung transplantation. Criteria for lung transplantation and listing the patients with pulmonary artery hypertension is being told. Potentially, whichever patients are not responding to the treatment, or there's a treatment failure, and if the reveal score is more than 7, and if there's a progressive disease and hospitalization and worsening of pH, need of IV or subcutaneous prostacyclin therapy, or if there's a suspected or high-risk variant of pulmonary vascular occlusive disease or systemic sclerosis, if there is a signs of secondary liver or kidney dysfunction, then the patient is taken. And the patient, if he's having recurrent hemoptysis, is also one of the indication for them to go for transplantation. So what are the recommendations for treatment decisions during the follow-up of these patients during the follow-up? Patients who achieve low risk status with their initial pulmonary artery hypertension therapy, they will continue treatment as recommended. Patients who are at low risk despite receiving endothelin receptor antagonists or phosphodiesterase inhibitors, adding selexipag should be considered to reduce the risk of clinical worsening. Riociguat may also be considered. Patients who are at intermediate high or high risk receiving oral therapies, addition of IV epoprostenol or treprostinol, and referral to lung transplant evaluation has to be considered. You can see this is group 1 patients. wherein the endothelin pathway and nitric oxide soluble glutamyl cyclase and cyclic GMP pathway has been targeted, and even the prostacyclin pathway has been targeted. The pulmonary vasculopathy has led into right heart failure, hence the symptoms of it. So one note about right heart failure is, whenever a patient is presenting to us with a right heart failure, what is the management what we are planning to do in the ICU care? So whatever is triggering the right heart failure in these patients, could it be infection, arrhythmia, anemia, or other comorbidities, has to be addressed as the first thing. Second is fluid management, which seems to be again core of this. Negative fluid balance has to be maintained in order to reduce the RV preload and then improve the RV geometry in the function. And with a low cardiac output, if the patient is having low cardiac output, then better treat them with inotrops. Basically preferred are dobutamine and milrinone, and targeted mean pressures are said to be more than 60 millimeters of mercury. And if there is a requirement to vasopressors, then NORAD or vasopressin are the two given drugs of choice for these patients. It's always necessary to avoid intubation and mechanical ventilation, because the risk will further deteriorate the hemodynamics of this patient, and they are always progressing to the death. So intubation has to be avoided at most of the time if it is possible. The role of mechanical support in these patients in the form of ECMO also has been taken over, but this is most commonly used as a bridging tool as a to transplantation if the patients are having irreversible right heart failure. Occasionally, ECMO can be used as a bridge to recovery patients if they have a potentially reversible RV failure cause. This is similar thing. The group 2 patients which are having left heart disease, basically left heart failure and other valvular heart disease patients who are progressing into PH. This is about the phenotyping of the patient. We can see in the column 3, it is pulmonary hypertension and the likelihood of it because of the left heart disease. Because the age of the patient is more than 70 years, they are known to have the comorbidities of more than 2, like obesity, hypertension, dyslipidemia, diabetes. Underlying left heart disease is present with the cardiac intervention has already been happened, and some of the arrhythmias like atrial fibrillation and structural left heart disease, ECG showing LBB and echo showing LA dilatation, LVH, etc. This is group 3 patient with lung disease, both COPD and ILD. The way we can see there is a remodeling of airways, and hypoxemia at rest and during exercise also is seen. Group 4, this is the workup of the patients who are coming with acute pulmonary embolism, or if it is said to be a chronic thromboembolic, then the workup is shown here. That is, PH workup is basically done. We go ahead with the perfusion scan. If there is any mismatch flow or there is a filling defect, then echocardiography is done to know the backward flow changes in the RA and RV. Then if we are suspecting there is a high probability of PH, then we are sending them to PH centers. If required, CTPA is done. If CTPA is inconclusive, then DSA also can be done. And if patients who have been confirmed, then they are said to be treated for CTPH. So patients who are confirmed with CTPH, they are said to have lifelong therapeutic anticoagulation. If they are said to be operable, then we can go ahead with pulmonary endarterectomy. Or if it is persistent or recurrent, then we can think of balloon angioplasty of the pulmonary vessel. Or if it is not, then medical therapy would be seen. So here we can see in the picture, if it's a proximal pulmonary artery fibrotic obstruction, then we can go about with a PA. If it is distal PA fibrotic obstruction, then we can go about with BPA. If it is microvasculopathy, then we can go ahead with a medical therapy. This is group 5 patients. We had seen the general classification as hematological disorders. In hematological disorders, it is sickle disease and chronic myeloproliferative disorder, which are the 2 most common presentations, 2 common class of people who are presenting with pulmonary artery hypertension. And systemic disorders, it is most commonly pulmonary Langerhans cysticercosis, which commonly present with them. A word about pulmonary hypertension center. Pulmonary hypertension center is said to have 2 side heads with the core MDT and extended MDT. Core MDT is known to have at least cardiologist, pneumonologist, along with cardiothoracic surgeon, intervention radiologist, cardiologist, study nurse, data manager, case manager, social worker, and nurse specialist. Whereas extended team basically includes adult congenital heart disease specialist, cardiac radiologist, cardiothoracic anesthetist, clinical genetics, genetic counselor, gynecologist, hepatologist, etc. So it's a whole log of a team which includes in that. So the take-home message or a key message from this updated guideline is hemodynamic definition of pH has been updated as mean pulmonary artery pressure of more than 20 milliliter of mercury at rest. Definition of pH also implies that the PVR is more than 2 wood units and pulmonary artery wedge pressure is less than 50 millimeters of mercury. Hence, the hemodynamic classification of pulmonary hypertension comes into picture. Main diagnostic algorithm for pH has been simplified following a 3-step approach, where first step is to suspicion by the first-line physician, detection by echocardiography, and confirmation by right heart catheterization in pH centers. Screening strategies for pH in patients with systemic sclerosis and in those at a risk of hereditary pH are proposed based on the results of the published cohort studies. Improved recognition of CT and echo signs of CTPH at time of acute pulmonary embolism event should help to remediate the underdiagnosis of the CTPH. The 3-strata risk stratification assessment has been refined. 4-strata risk stratification divides into large intermediate risk group into intermediate low and intermediate high risk. Treatment algorithm for pH has been simplified with a clear focus, which is telling us to risk assessment, cardiopulmonary comorbidities, and what are the treatment goals for every patient. And treatment algorithm for CTPH also has been modified, including multimodal therapy with surgery, pH drugs, and BPA. Thank you.
Thank you, Dr. Tejashwini. It's very nice and elaborate. Manoj, are you able to hear me?
Yes, sir. Yes.
Thank you, sir.
Sir, there is some question in the chat box.
One, Dr. Kirti had asked about suprasystemic PA pressure in an adult patients. But he has not mentioned what type of clinical situation it comes into play. Because suppose it's a left heart disease, then it is a secondary to your pulmonary venous hypertension. Okay, it's a very late stage with the suprasystemic PA pressures. Okay, so and if it is a chronic pulmonary embolism, then it is a because of the obstruction in the pulmonary artery. Both are in a different set of patients where your treatment will be different. Because if you have an obstruction, and most of the time the suprasystemic pressures with the RV dysfunction, so they will decompensate very fast. If any adult patient comes with a suprasystemic PA pressures, the first thing you have to do is give a 100% oxygen, because your oxygen is going to be the one of the best pulmonary vasodilator. And if it is in the perioperative period, or you are planning for any intervention, or if it is in the critical care area, then if the patient is not having a very low saturation, that is basal saturation is very low, not in an acidosis, then not in a severe RV failure, then you can manage without intubation. Or if the patient is in any of these 3 conditions, then you may have to electively intubate with a controlled ventilation and correcting the acidosis, hypercarbia, and hyperoxygenation. Then in addition to that, if it is not due to the left heart obstructive disease, then you can start a specific pulmonary vasodilators. It can be an ionodilator, or it can be even sildenafil. That is how is in adult patients it is coming. But most of the time, what we look at in a clinical scenario is only 3 set of patients with a severe PAH. Because most of the time, as an anesthetist, we will not have we will not be exposed to the primary pulmonary hypertension. We may be having a patient posted for pulmonary thromboendarterectomy, coming with a severe RV dysfunction with the PAH. Then you might be having a left heart disease Most of the time, it's a severe pulmonary venous hypertension with a superadded pulmonary arterial hypertension. And third set of patient is a congenital heart disease with a large left to right shunt patient. Okay. So as I told you, in a CTPH, that is the main thing is your RV dysfunction, which is very important to manage. Then the left heart disease, you may need an aggressive diuresis and an inodilator with the to manage the PAH. But when it comes to the left to right shunt, then your basal saturation will give you rough idea about how much the systemic pressure is going to be there. Okay. So it's a duration and the age of the patient and the magnitude of the shunt, which is going to give you a rough idea that whether these patients are having a hyperkinetic PAH, flow related, or they might be having some vascular changes. You can, information can be roughly guessed from the room air saturation of all these patients. Because if you look at the most of the flow related hyperkinetic PAH on room air, they will have almost like 100% saturation. That means they have a large pulmonary blood flow. So your pre-CPB aim will be to reduce the pulmonary blood flow. In a sense, you don't want the patient to go into a pulmonary flooding. So you do all the maneuvers not to increase the pulmonary blood flow. So you don't want to decrease your PVR and you don't want to increase your SPR. So you want to balance it. So what roughly I recommend is that you try to maintain your saturations with around 90%. You don't want 100%. So you reduce your FiO2, you don't hyperventilate, and that. So that is one thing. Suppose the same patient coming with a room air saturation of 92%. That means that patient even having a borderline PAH, because a patient with a left to right shunt, common quiet patient, if having a saturation around 92% or lower, that means the PVR is quite significant, which reducing the pulmonary blood flow. So these are the patients will go into a PAH crisis in the perioperative period. So you have to manage in a different way. You may have to have a little higher FiO2. You may have to have a little hyperventilation. So this changes. Now coming to the combination therapy for PAH in an adult for a secondary PAH, because primary PAH, you know that there is now the dual pulmonary vasodilator they are giving and repeating it. For a secondary PAH, right now you are having is you can use an inodilator with the what you call IV sildenafil, PDE5 inhibitors. That you can useful. But when you are using a sildenafil IV, I normally prefer to not to use either milrinone or levosimendan because that combination effect is more. So when you are using a sildenafil, you can go for any other inodilator like relatively dobutamine or something like that. Any comments? Dr. Kirti can write. So normally for me, if you are having a primarily RV dysfunction, then still I prefer levosimendan. But if you are having a primarily PAH is more than your RV dysfunction, then your milrinone scoring little over than your levosimendan. That is how I look into that. Then now this PAH therapy moved on to like preoperatively, the borderline cases where you may not be able to operate immediately. They put the patient on oral pulmonary vasodilators and wait for 6 months to even 1 year. Ask them to come back, reassess, then do the surgery. this preemptive nitric oxide, Dr. Kiti asked, see, the nitric oxide usage in adult depends on what type of cases you are using. Okay. If you are having a transplant patient with the right heart study where the PVR is high, it is more useful. But for a valvular disease, especially the left heart disease coming with a severe PAH, I have not seen much effectiveness with the nitric oxide, but still nitric oxide can be useful in adult patient also. Preemptive is depending on how you feel about the PAH. If you are thinking that, because in a congenital heart disease, like patient with a TAPVC, or you have a truncus arteriosus, still there is a role for preemptive or prophylactic nitric oxide is there. Even when you are able to come up with a patient with other inodilators, still you use the nitric oxide. But in adult patients, I have not seen much usage with the nitric oxide. But effectiveness wise, inhaled prostaglandins are much more effective than your inhaled nitric oxide because they're relatively cheaper and less toxicity and easy to administer. Any other questions are there? As I told you, pre-capillary PAH, most of pulmonary venous hypertension. Sorry. Yeah. If you have a pulmonary venous hypertension, that will not be more amenable for your pulmonary vasodilators, because there you have to treat like a left-sided heart failure, where aggressive diuretics, then after detection, this will be more useful than your PAH treatment. If you are having a pulmonary arterial hypertension, then your sildenafil may be more useful. If you have a both, that means you are attacking like both. That is what will happen when you have a pulmonary venous hypertension. Then you will have a superadded pulmonary arterial hypertension. Initially, it will be a reflective, means reactive component. Later, it may develop a vascular changes. So in that situations, definitely sildenafil will be useful. But when you are using a sildenafil with the other inodilator, always very, very careful. And the one more comment about using a vasopressors in a PAHs, even though noradrenal is a very good choice, but remember, beyond a particular dose, especially when you exceeding the dose more than 0.1 mic per kg per minute, it can adversely affect your pulmonary vascular resistance. So it's always better to use vasopressin, which is also a pulmonary vasodilator also. So if you know that you are using an excessive vasopressor, it is always better to use a vasopressin rather than noradrenaline. Otherwise, there is no contraindication for using a noradrenaline in PAH patient. PH with the liver failure is most of the time, it's you have an RV dysfunction with the congestion. So if you treat your, if you are able to reduce your RV congestion by reducing your RV afterload, improving the RV contractility, the liver failure, if it is only the congestive liver failure, it might improve. It may improve. Only thing you have to look into the pharmacokinetics of pharmacodynamics of the drugs which you are using in case of liver enzymes are elevated. But most of the time, when you look at the liver congestion, you go ahead with the surgery, and if you are able to maintain the cardiac output and RV afterload, it really helps to improve the liver function over a period of time in the immediate post-op. Anything else? If we don't have much questions, then Rahul?
So, Dr. Rahul is not here.
Okay.
You can wind up the session.
Okay. Really, it was very nice to interact with the students, and I'm really thanking all the students and all the participants for being here at Saturday evening. Last question somebody asked about the Dr. Kirti about the AV malformation. I'm not sure if you have a PH because of the AV malformation, whether anything can be done. I'm not sure about that, because most of the time we may not have, we won't be having this kind of patients to deal with, except it is a post Glen or a post Fontan. That also the options are very, very limited. So I'm very happy to be here at the Saturday evening, this many students, and with quite active participations. Thank you very much. Thank you very much.
Thank you, sir. Thank you.